that guy from Hartford Healthcare signed up?
No. We are going to get started in a few minutes. We're just waiting for a few more people to join. Thank you. We will give it one more minute and we will get started. So Rod, why don't we get started?
Great. Thank you, Kathy. Good afternoon and welcome to today's webinar. My name is Roderick Marriott. I'm the director of the Connecticut Department of Consumer Protection's Drug Control Division and a member at large in the executive committee of NASCSA. I'll be hosting this afternoon's webinar along with Kathy Camille. Hopefully you read the scrolling materials while waiting for the webinar to start, which provide information regarding our sponsors, a NASCSA disclaimer, housekeeping items, and announcements. Thank everyone who attended our annual conference and celebrated our 40th anniversary with us. We had a fantastic turnout and some amazing sessions. One quick thing to note, our CE for pharmacists and pharmacy technicians on PMP data integrity has renewed. For more information on it, please reach out to Chelsea Townsend. We encourage everyone to send it out to their pharmacists and pharmacy technicians across their state. Today's webinar and all our webinars throughout the year would not be possible without the generous support of our sponsors, so thank you to our sponsors. And thank you for taking time out of your day to join today's webinar on Stimulants 101, what state leaders need to know. We are excited to have Francis McGaffey and Camille Clark with us today. Please allow me to introduce them. Francis McGaffey is an associate manager for Pew's Substance Use Prevention and Treatment Initiative. Prior to this role, she worked with other Pew teams on state and local fiscal health and worked on improving healthcare in jails and prisons. In her current role, she leads research to support state and federal efforts to expand access to substance use disorder treatment. Her areas of focus include using data to inform treatment policy, options for increasing the availability of methadone on the state and federal levels, and strategies for increasing access on high-quality care for alcohol and stimulant use disorders. She holds a bachelor's degree in political science from Vassar College and a master's in public policy from George Washington University. Camille Clark is an associate one with Pew's Substance Use and Prevention Initiative. She's a member of a research team that conducts research to provide analysis to inform state and federal policy work relating to treatment for substance use disorders. Prior to her role, she worked with research consulting organizations to improve behavioral and mental health policy within the DC metro area. She holds a bachelor's degree in public health science from the University of Maryland. Welcome, Francis and Camille. The floor is yours.
Thank you so much. And thank you, Rod and Kathy for the introduction, and thanks to all of you for joining us today. Let me get my slides up and we will dive in. Let's see. I gotta make sure I have my notes as well so I know what I'm saying. There we go. Camille, can I get a nod if it's looking right? Great, thanks, Camille. As Rob mentioned in his introduction, we're with the Pew Charitable Trust. Pew is a nonpartisan nonprofit research and policy organization, and through our substance use prevention and treatment initiative, we work to advance state and federal policy change to increase access to high quality care for substance use disorders. And today we'll be talking about stimulants. More specifically, we'll be sharing key insights from our recent publication, Stimulant Use is Contributing to Rising Fatal Overdoses. We'll cover what stimulants are, why it's important to address stimulant use disorder and stimulant use to protect public health, and strategies for addressing stimulant-related harms. At the end, I also put in a slide that has some additional resources that may be of interest, and I think Kathy might be able to send that one out to you. So let's start with what stimulants are. I think as controlled substance administrators, you're probably well aware, but as a starting point, they're drugs that increase feelings of euphoria, of excitement, of alertness, right? So the uppers. And people use them for a lot of reasons. Sometimes it's functional to stay safe and alert while experiencing homelessness, right? To avoid possessions being taken or being victimized, to avoid excessive sedation from opioids if someone uses both substances. People use them to improve their performance at work or at school, or to lose weight. And of course, people use them for pleasure because it feels good, including to enhance sexual experiences for some people. You can see in this table the three main types of stimulants: cocaine or crack, methamphetamines, and prescription stimulants, such as misused Adderall or Ritalin. Patterns of use vary across the country. Though all three forms are available across drug markets, cocaine is the more commonly used stimulant in the South and the Northeast, while methamphetamine predominates in the West and the Midwest. When it comes to prescription stimulants, surveillance data can be a bit harder to come by. One reason is that in death investigations, it's hard chemically to tell these prescription stimulants apart from methamphetamine. So they're often classed together in a category called psychostimulants. Okay, so why do we need to understand these, right? A lot of you are here because you know the answer. They have a major public health impact and one that's been increasing. So you can see in this figure, stimulants are increasingly appearing in fentanyl overdoses. In 2010, less than 1% of these fatal overdoses involved stimulants. But by 2021, that rate had jumped to 32%. So that is the darkest line you see on the graph, right? You can see that the dark blue line, that's fatal overdoses without fentanyl or stimulant, that's essentially heroin, that's really dropped. And we're seeing overdoses involve some of these novel substances, including the combination of stimulants and fentanyl. And that combination is important to understand. Using more than one substance is known as polysubstance use, and it's really common among people who use drugs. In many cases, this combined use is intentional. So the user either co-administers the drug simultaneously, or they use opioids and stimulants at different times. So like I mentioned before, maybe using stimulants to counter some of the sedating effect of an opioid. And on occasion, the combined use is accidental, where a stimulant has been contaminated with fentanyl. However, they're combined, opioids and stimulants taken together increase overdose risk. And this risk is heightened among people who are predominantly stimulant users. Those folks who don't regularly use opioids, they may not be as aware of the need, for example, to carry naloxone, not use alone, and test their drugs for the presence of fentanyl. And as with nearly all issues in public health, the risk is not evenly spread across the population. Black and American Indian or Alaska Native populations have the highest rates of stimulant-involved deaths. So in the figure on the left, you see the rate of cocaine-involved deaths. And if you look at that dotted or dashed line at the very top, that is the rate among Black people. And you can see that is much higher than any other race or racial or ethnic group. And then on the right, you see a similar pattern with psychostimulants, which is often methamphetamine, among American Indian and Alaska Native populations. So that black line is American Indian, Alaska Natives, and it far outseeds other racial and ethnic groups. When considering the public health impacts of stimulant use, it's also important to distinguish a stimulant overdose from one that involves opioids. So by now, most of us are familiar with the key feature of an opioid overdose: respiratory depression that, if not reversed, leads to death. But you can see from the array of symptoms on this slide that a stimulant overdose can present in a lot of different ways and very differently than an opioid overdose alone. So to distinguish the two, stimulant overdoses are often referred to as overamping. And the appropriate response to a stimulant overdose really depends on the symptoms and the severity. So in a more mild case, you might be able to help someone by providing a cool, wet washcloth, giving them plenty of water, giving them a calm place to be to let their nervous system calm down. But people can also be at risk or experience really serious health complications like a heart attack, a stroke, or a seizure. So in those situations, of course, it's really important to get them emergency medical attention. And then because stimulants and opioids can be combined, either intentionally or unintentionally, if you suspect that someone has taken stimulants and an opioid and is not breathing, naloxone should still be administered. If it turns out they haven't taken an opioid, they'll be fine. The naloxone just won't have an effect. Okay, so we got a pretty serious public health problem on our hands. And fortunately, there are strategies to help. So the first strategy, right, with many health issues is screening. Not a lot of people with a stimulant use disorder get treatment. We know that widespread screening, as recommended by the U.S. Preventive Services Task Force and the American Society of Addiction Medicine, can increase the rate of early detection, right? So getting people who have a less severe stimulant use disorder into care, and just overall increase linkage to treatment among those who want it. Screening can take place in both primary care settings and in hospitals. And there's a few things to think about when implementing screening. First, it's important to use a standardized screening tool, right? So you can trust the results you're getting. It's also so important to use judgment-free, non-stigmatizing language. That increases the likelihood that the person will disclose their stimulant use. And then a positive screen needs to be followed up with appropriate care that meets the patient's needs and wants. So if someone is ready and willing to go to treatment, linkage to that care. If not, some health education, some harm reduction services can still be beneficial. And on that note, screening can also detect people who use stimulants but don't meet the diagnostic criteria for a stimulant use disorder, right? So they might use just on the weekends and it's not having that many major impacts on their life at that point. Well, it's still important that these more casual users have information about the potential health risks of stimulant use and know where to go to reduce harms. And now Camille is going to talk to you about our best treatment option.
So, to treat stimulant use disorder, right now, the best treatment or the standard of care is contingency management. And unlike medications for opioid use disorder, there are no FDA-approved medications to treat stimulant use disorder. Therefore, again, according to ASAM, the standard of care is contingency management, or CM, which is also the standard of care for stimulant use disorder patients within the Veterans Health Administration. CM is where patients are rewarded for changed behavior, and in stimulant use disorder, it's reinforcing treatment attendance or stimulant abstinence. There is a protocol to implementing CM where the provider and patient agree on one objectively verifiable target behavior that is both related to stimulant use and can be achievable by the patient. Common target behaviors are treatment attendance or stimulant abstinence. The provider monitors whether the agreed upon behavior occurred, usually through a urine drug test to verify stimulant abstinence. This monitoring occurs 2 to 3 times a week. If patients demonstrate compliance with the agreed upon behavior, they are rewarded immediately, often with gift cards greater than $5 or $16. Successive demonstrations of compliance with the behavior earn increased rewards. If patients don't demonstrate compliance, they do not receive the reward, but are encouraged to try again. The treatment should last a minimum of 12 weeks, though longer durations are more effective. Adherence to the protocol is essential in reaching and maintaining positive outcomes, which include longer durations of stimulant abstinence during treatment and higher rates of adherence to treatment than other behavioral therapies, as well as a higher likelihood of abstinence at follow-up than those in other forms of treatment. There are federal barriers that inhibit proper CM implementation. The number one barrier is regarding incentives. So states and organizations are cautious in providing CM and CM incentives due to fear of violating federal fraud and abuse laws that prevent providers from using incentives to influence patient choice. Additionally, states and organizations that use only SAMHSA or federal dollars are limited to providing in total incentives up to $75 per year, which is far below the research-based cumulative amounts of $400 to $560, which can be effective at reducing stimulant use with greater positive outcomes as amounts increase. To avoid invoking federal fraud and abuse laws, as well as increasing incentive amounts, states can apply for Medicaid 1115 waivers. For example, in California, the first state to be approved to implement CM under an 1115 waiver can implement CM without fear of invoking the federal fraud and abuse laws and allows them to provide incentives greater than $75 at $599 per year. Although 4 states, including California, Washington, Montana, and Delaware, have been approved through the 1115 waivers to administer CM, this is not possible for all states. This is due to administrative capacity, cost of drafting the waiver, and lack of Medicaid guidance on what the protocol should include when developing the waiver. Financial and administrative barriers include staffing. So some things to think about are whether outside staff needs to be hired or the capacity of current staff. Site readiness. So what organizational factors contribute to administering CM, whether it be organizational size itself or funding, and also the ability to provide staff education and ongoing coaching. It's also important to consider incentive tracking. For some providers, this may be time-consuming and burdensome. Another important barrier is stigma. So many people, including policymakers, clinicians, and even treatment staff, assume that contingency management is paying people to not use drugs, although it's not. The incentives make the stimulants less rewarding, influencing people to not use the stimulants. And this kind of reinforcement is something that we use in everyday life, where people are rewarded for change or positive behavior.
Thanks, Camille. Another treatment option is actually medication. I know Camille just said there's no FDA approved medication, and that's true, but there are off-label drugs that can help. Research looking at these drugs finds benefits including reduced cravings, less drug-seeking behavior related to those reduced cravings, reduced depression severity, and improvements in overall functioning. There is less evidence that these medications can produce abstinence, but that's not always someone's treatment goal. So these benefits can still be really important, and someone can always combine medication treatment with contingency management if abstinence is their goal. So based on the evidence, the American Society of Addiction Medicine and the American Academy of Addiction Psychiatry released a practice guideline that endorses the use of some of these medications. So for example, because there's a whole lot of them and different situations in which you use them, so I'll just share one. Bupropion is approved to treat depression, seasonal affective disorder, and for helping people quit smoking. Naltrexone is FDA approved to treat opioid and alcohol use disorder. When combined, they've been shown in clinical trials to help people reduce their methamphetamine use. ASAM and AAAP notes that this combination or other combinations discussed in the guidelines might be particularly helpful for someone who also has one of the indicated conditions. So in this example, someone who wants to reduce their stimulant use, and they also have depression. So you should expect a benefit from both treating the depression and reducing their stimulant use. You might be wondering if any of these medications are in themselves stimulants, since we treat opioid use disorder, for example, with opioids such as buprenorphine and methadone. The answer is yes, but ASAM says to proceed with caution given risk and just not a huge evidence base at this time. So I put an excerpt from the practice guideline up on this slide. Basically, ASAM recommends that only doctors with the proper training, so doctors certified in addiction medicine, try this strategy, and they recommend that these providers closely monitor their patients. So we probably aren't seeing a lot of this just because there are simply not that many providers who are certified in addiction medicine. But I did want to mention this, especially for you all, since I know you carefully monitor what you see in your PMPs, and in case you see increases in some of these medications that are on the slide, it might be interesting to see if they're being used for treatment purposes. So like I said, there's just some examples of stimulant medications that can be used, and you'll note that commonly a longer acting form is what's recommended. And there is a possibility that we will see some FDA-approved medications for stimulant use disorder in the future. Last October, the FDA released draft guidance for drug development that indicated openness to evaluating drugs on clinical endpoints other than abstinence, which has historically been the goalpost, and as I mentioned earlier, has not historically been achieved. This guidance document mentions several possible alternative endpoints, such as a reduction in how many times a week a patient uses stimulants, or the percentage of patients who reach what's known as early remission of stimulant use disorder as defined by DSM-5 criteria. And that means meeting none of the criteria for stimulant use disorder for a period of time between 3 and 12 months. The guidance also mentions openness to patient-centered outcomes measured through novel instruments. So these could be trials looking at how well a patient functions overall, or even their ability to resume work or education. But this draft guidance was issued over a year ago now and has not yet been finalized. We will have to continue to wait and see if we get a final version, and then if drug developers take FDA up on this opportunity to do some new trials. The last approach to stimulant use we'll discuss today are life-saving strategies, also known as harm reduction. So first, because of polysubstance use, like I mentioned before, it's really important to provide people who primarily use stimulants with naloxone and drug checking equipment like fentanyl test strips so that they can stay safe from an opioid overdose. Next, like all people who use drugs and everyone, people who use stimulants need stigma-free care that makes them feel comfortable disclosing their use and getting the services they might benefit from. Housing is another important part of the equation. Access to stable housing and housing first programs, so those are the programs that don't require abstinence for people to get housing or stay housed, can decrease substance use and related physical harms. Next, syringe services programs can help people who use stimulants. So these programs distribute free new sterile needles to people who inject drugs. Historically, they focused on those with opioid use disorder, but these programs can also serve people who inject stimulants, reducing their risk of HIV and hepatitis C. And these programs can also expand to include services for people who administer drugs nasally or smoke them. So they can provide supplies, safe, clean supplies so that people aren't sharing their equipment and risking infections. I mean, we have seen syringe services programs taking up this challenge. And then finally, safer sex supplies and the medication regimen known as pre-exposure prophylaxis or PrEP can reduce the risk of STIs, in the case of PrEP, HIV transmission. And that risk is higher among people who inject stimulants and certain populations of people using stimulants when engaged in sexual behavior. We're wrapping up. Here are the resources I mentioned that we'll share. And here is our contact information. And I'm gonna stop sharing and I'm really excited to hear your questions.
I actually have a couple of questions, if you don't mind. This will show you that I was actually listening. So, what percentage of prescribers are actually using this contingency management? Because truthfully, I've never heard of it before.
Yeah, we don't have a definitive answer, but Camille, go ahead. Talk about the state of CM as we know it right now.
So people in states want to use CM, but they don't have the ability or they don't know where to go to use CM and what kind of implementation factors they need. So for right now, we don't understand. And I could definitely get back to you about that though.
Yeah. So we do know several states have gotten approved 1115 waivers. There's more states that have pending waivers. But I think it's also important to understand that implementing CM through a Medicaid program is really complicated. There's a lot of safeguards state Medicaid agencies will have to put in place to, make sure they're not violating those fraud and abuse laws. So it is hard to set up a CM program, and even harder if you're trying to do it the right way with fidelity to the evidence base.
So I certainly understand that 1115 waiver is a tough road to hoe, but I'm curious whether there are any states that have implemented it via private insurance or through ACO programs. Because then you don't have to go through the 1115 waiver necessarily.
There are states that do provide CM or fund CM through like collective or blending and braiding funding. So some states appropriate money specifically for CM. Some states use SAMHSA dollars as well as state revenue, or they'll use SAMHSA dollars, state revenue, as well as the opioid settlement money as well. But it really just depends on the state and what they have to use.
And then in commercial insurance, I don't have data on the penetration rate, but there is a digital product that got an advisory opinion from the Office of the Inspector General. So that's basically assurance that they won't be prosecuted for violating federal fraud, waste and abuse acts, and that digital platform does have agreements with some commercial insurers.
So Rod, do you want to read any of the questions in the Q&A section, or do you prefer I do it?
No, I'm happy to read them, Kathy. There was a question about naloxone being helpful for stimulants in OD, but it looks like that one got answered. There's a question: is there a standard screening process that can be advocated for stimulant use disorders?
So there are a variety of validated screening and assessment tools. And actually, NIDA has a really nice table of these, and it talks about the types of substances they use and how they can be administered. So I will share that. So the ultimate decision on which screening protocol to use, right, depends on how much time you have, right? You might not have a lot of time for your clinicians to spend going over this with patients, so you might want a shorter one. If you have more time, you can maybe do a more comprehensive one.
Thank you. The next question is, has the increase in fraudulent online pharmacies providing counterfeit stimulants increased the accidental overdose by including fentanyl or other dangerous drugs in their formulary? Or formulary? Maybe formula?
I am not aware of any recent data that points to this particular problem. What we do know is that when drug checking services have looked at samples of seized drugs or drugs provided by people who use drugs, we're seeing really variable rates of contamination. I think honestly, on the higher end, we've seen 15%, and we've seen lower in a lot of places. And so it really varies. It varies by region and drug market, and the form that the drug comes in. So basically, it's hard to say which drugs might be contaminated, which is why it's important to get this message out about drug checking.
Thank you. The next question we have is there any information as to whether there will be guidance from professional societies for ADHD drugs for adults? Presently, nothing exists, and it is causing a lot of stimulant abuse, especially through telemedicine.
Could the person who asked this question say a little bit more about like what type of guidance they're hoping to see?
I think it's any guidance on the proper treatment for adults is basically what as I've reread it. So there is a lack of information on the appropriate use of stimulants for adult patients in general.
Gotcha.
And perhaps the American Academy of Psychiatry or any of the other kind of associations could come out, or do you know of any guidance that's in process from them?
Gotcha. So the appropriate use to treat things like ADHD.
Mm-hmm.
I'm not
Especially with
aware.
telemedicine, right? So we've seen a lot of telemedicine kind of impact stimulant prescribing. And if you look around the country, there's roughly on average 19% increase in stimulant prescribing over the last few years. And that's been pretty impactful. And so I don't know if you knew of any societies that were taking up that issue.
Camille, it looks like you wanted to jump in.
I will say I'm not sure of any societies that have some kind of guidance, but I will say as far as being diagnosed with ADHD, there isn't, according to ASAM, any data that suggests that those diagnosed with ADHD will do or are likely to develop a stimulant use disorder. Yeah.
Is Pew working on anything to kind of research the increase in prescribing and see how how that can impact this? Because I know you guys have a lot of different irons in the fire.
Yeah. Not right now, but that's definitely an interesting question.
Maybe how telemedicine can be properly used to diagnose ADHD.
Right. Yeah. Because
Maybe
we
some
certainly
guidelines.
don't want people who need it to lose access, because we know telemedicine has been so beneficial for a lot of people. So it does need to be approached carefully.
Anyone else have any questions they want to type into the chat at this point?
I don't see any more.
We'll just give people one more minute.
I think I don't see any more, so I think we can wrap it up.
Great. Well, this has been fantastic. Lots of great information in a short time. Thank you for sharing your insight and expertise. We really appreciate it. I feel like the audience has also appreciated it, and is grateful for your time. I'd love to thank our speakers, Francis and Camille, again. I hope that the members of NASCSA found this educational opportunity to be helpful. And I'd like to thank everyone who's joined us today. And as always, thank you to our sponsors, because without them, none of this would be possible. We hope everyone has a wonderful day and signs up for the next webinar.
Thank you.
Thank you all.
Yeah.